Good afternoon. Is everybody still awake after the postprandial uh, coma time? I can't thank you guys both enough for the perspective you offered. It takes a lot of courage to get up here and talk about something as personal as that. A lot of courage, and I'm overwhelmed, to be honest. This is our day-to-day medicine. We take that for granted a lot, but our day-to-day can be really, really hard sometimes. We can bear witness to some of the most unfair situations imaginable, like Yvonne's son. And, it's deeply humanistic what it does to families, what it does to us. I'm going to talk about burnout because that's a really, really easy aspect of humanism to measure. But please know that when we talk about burnout, it touches on moral injury. It touches on sadness. It touches on disengagement. It touches on all these other aspects of who we are as people. And how we bring that to our practice of medicine. I'm going to take a brief step back to define burnout because it's such a ubiquitous term in today's parlance. Merriam-Webster describes it as exhaustion of physical or emotional strength or motivational. So it's very multifaceted. It's not the same for different people. And it's usually at the result of prolonged stress or frustration. It's not the same thing as stress. It's not the same thing as frustration. We all chose stressful careers because we enjoy them. There's nothing wrong with stress. It's when that stress is too big, too frequent, it's unmitigated, and we don't get to recover in between. Since we're going to be talking about measuring, the most common metric to measure burnout is the Maslach Burnout Inventory. It was developed in 1980 by Christina Maslach and her colleagues in California. And it looks at burnout as an aspect of three domains, basically. This idea of emotional exhaustion, you just got nothing left in your tank to give to your next patient, to give to your family and friends, or to give to yourself. A low sense of personal accomplishment or a feeling of inefficacy, this idea that you're not appreciated for what you're bringing to the table, or you're not really making a difference. And depersonalization or cynicism. That's a big one for us. We depersonalize as a mechanism of our workflow. You're taking care of the lap chole in room 5. That's depersonalization. There's nothing wrong with it unless you're routinely using it as a coping mechanism. So for me, it's my big early warning sign that I'm getting burned out when I start making sarcastic jokes. Other people may think it's funny. Other people are laughing along with me, but I recognize it's a red flag. I need to take some steps back. When we talk about this metric, if you have a threshold level of emotional exhaustion and or depersonalization, most people classify that as being, quote, high risk for burnout. In the studies that I'm going to show that our group did, we also discuss a more severe subset called burnout syndrome, which is kind of in line with the World Health Organization definition, which basically means you have reached a threshold level of all three domains at once. I'm going to talk about anesthesiologists, attending anesthesiologist research. There is every reason to believe that much of this data is extrapolatable to nurse anesthetists, to nurses, to medical students, to other members of the healthcare workforce. But in 2021, we published the result of a survey that was sent out by email in March of 2020. I don't know if you remember March of 2020. Probably the poorest planning for survey timing you can imagine. But that's when we did it. That was when COVID had not yet reached our ERs for the most part, but they had definitely reached our inboxes. So we were happy to have a fairly robust group of survey respondents. Nearly 4,000 US attending anesthesiologists, members of the ASA, responded to this survey. And we found that, along the same lines as other physicians, we had emotional exhaustion, depersonalization, and a low sense of personal accomplishment. 59% of respondents were at high risk for burnout, and 14% were burned out. So what? That's just a number. What mattered to us were the other 13 questions based on demographic and practice factors that we asked, and what was their association to burnout. Now, without getting too much into the weeds, we did a multivariate regression analysis looking at which of these factors impacted or was associated with, I should say, being at high risk for burnout or having full burnout syndrome. And what you'll notice about this multivariate regression analysis is that you've got like your smattering of factors that fall along the odds ratio of 2 line, things like not having a lot of support at home, being in the LGBT community, working full time. And then there's one factor that just jumps off the page, and that's espousing little to no support in the work life. If you say you have little to no support in your work life, your odds ratio of having high risk for burnout is about 7, and it's 10 for having full burnout syndrome. That's massive, to the point where there's several hospital systems that now use this as a snapshot picture to see where I like to call it gross departmental morale lies. And so where are we right now? How supported do you feel? Obviously, that's the beginning of a conversation and not the answer, okay? After 2021, some things happened. Well, we had a pandemic and all that came with that, both to our professional lives and our lives in society. We, for the first time, probably worried how we comported ourselves at work was a risk factor for our family's health when we came home. Were we exposing our families? We didn't have the same support structures that we did before. We couldn't socialize in the same way. Many people were quite isolated during this period of time. We couldn't shop the same way. We did things completely different. We dressed differently. We looked different at work. In addition, we had an incredibly contentious political period that continues to this day. That is a stressor. That is a strain on the system. We have had a national reckoning, long overdue, about racism and systemic injustice. There's a lot of stuff that's happened. A lot of, as I would say to my 9-year-old son, a lot of big feelings, okay? So we repeated this study in November of 2023, or 2022, excuse me, and we found that everything kind of worsened. And this is in line with what we've seen from other physician groups. It has come down in those physician groups since this time. We have not yet repeated this one again, but everything kind of went up. Again, these are numbers. This is not what you came here for. We asked some more questions and we got some geographic information here. There's certain hotbeds of burnout that are important to know about. And what are we doing with that information? Well, the first step I took, as I'm chair of the ASA's Committee on Physician Well-being, I specifically looked for applicants to the Committee on Physician Well-being from this dark blue area, so I could get a little bit more representation into what is going on there, what's modifiable, what's leading to this. Again, it's the start of a conversation, not the answer. We looked at it based on what is your subspecialty in anesthesiology. This is my personal recruitment tool to the field of pediatric anesthesia, if anybody's interested. But critical care certainly bore the brunt of the pandemic, but nobody's immune, and it really does fall out that everyone is still at fairly high risk to this day. We looked at changes to plans in working. Has COVID accelerated your plans to actually retire? Accelerated them. Nearly 40% of people said it accelerated their plans to retire. That's significant. This is a snapshot in time, but when we said, how likely are you to leave your current job in the next 2 years, 35% of respondents said they're likely or very likely to leave their job. These are attending anesthesiologists in the US. 35% say, I'm likely or very likely to leave my current job in the next 2 years. That's a lot. And how many have reduced their employment status? 25% had already reduced their employment status through the pandemic. And then, let's see. Oh no, that was the one, if you plan to do so in the next year. Excuse me. So 25% had either done so already or planned to imminently. So it's probably already in the works. When we asked, what do you think is going to help? The number one thing is staffing. Raise your hand in this room if you currently have staffing shortages in your place of work. Okay, staffing shortages is why I couldn't come to the thing last night. But adequate staffing is the number one thing. Okay, when you ask people what's going to make your job better, 9 times out of 10, the first couple answers are money and time in some kind of combination of that. But when we ask this group of people what's going to make your life better, their first 2 answers are adequate staffing and better morale or culture, and then money and time. But it is significant that the top 2 things have nothing to do with money and time. It has to do with resources. Give us what we need to do the job we came to do, and do it safely. Same thing. If you said you had little to no support in your work life, your odds of having burnout or being at high risk for burnout, astronomically higher. So what is it about this job that is so hard? We've heard some of it. We are human beings who are very intelligent, who are very hardworking, who are very resilient people who have chosen a career to dedicate our lives to, so that we can build a skill set to bestow a very specific and highly skilled form of kindness on our fellow man. And when that doesn't go right, it hurts. That's what it boils down to. That's why this job is so hard. We pour our heart and souls into it, and sometimes it goes sideways. Miracles aren't always easy. We love to compare ourselves to the airline industry, but we are not the airline industry. When the miracle on the Hudson happened, every member of that crew, and that was a miracle. I mean, nobody was killed. Nobody was seriously injured. Everyone on that crew, including the control tower, was mandated time off and had to have a psychological evaluation before coming back. That is not how we handle miracles. We pull off miracles all the time. And sometimes they're really hard on us. And I can ask you, if you're waiting for your flight to take off and you go up there and Sully Sullenberger's there and you're like, wow, the miracle on the Hudson guy, right? You spoke at the ASA. But if you go up and you look down and his shoes are still wet from waiting off his plane in the Hudson, I bet it would give you pause and you'd wonder, are you in the right frame of mind to be working? And I bring that up because, again, we are not the airline industry. We have to work with wet shoes a lot. And we need to understand how that impacts us and how to support one another through that. What is the normal response after something going really badly, after a medication error, an adverse event, perioperative catastrophe? Sue Scott is an incredible nurse educator. She did this study where she asked people what was their process of recovering. And I love this table because it's everything. You can have physical symptoms of hypertension, tachycardia, not sleeping. You can have all sorts of psychosocial side effects. You can have grief, remorse, worrying about your reputation, not wanting to go in the same room again, being mad, all sorts of emotions. They're all fairly typical after a major event. When we asked anesthesiologists, that's my cue, they got 2 minutes left. When we asked anesthesiologists about perioperative catastrophes, most of them required time off. Most of them required time to recover from the event. 1/5 of them never did. And a lot of them considered leaving the job entirely. But what's amazing is that 2/3 said that the care they provided in the next 4 hours was compromised. They admitted to being an impaired clinician. At that time, only 7% were given any time off. We're hoping to repeat that study for anesthesiologists this year, and maybe even bring in nurse anesthetists in that process, which would be lovely. I'm going to pause over these. Just want to give the other speakers time, but if you take nothing away from my time, it would be this. Again, we experience extraordinary human events on a fairly frequent basis. After those events, whatever you are feeling, however you are responding, it's okay. It's normal. It is normal to have normal human responses to extraordinary human events. That doesn't mean you don't need help. It means that you're okay. All right? So if you remember nothing, remember that. Thank you, guys.